Thanks, for Chairman. And good morning, ladies and gentlemen. It's really a great honor for me to be here to share what our colleagues have done in embryology, embryo technology. And so to be here, I will share several posters and oral presentations in ESHRE with you. Though some of them are not perfect, but we do wish and believe that they could inspire us and to modify them and then to design better studies for us and for our students. So today, my topic is update and progress. Sorry. One of the key developments in recent years in embryo technology is the time-lapse imaging system, such as we can now see that what happened in the incubator, because as you know, there are two black boxes in IVF area. The one box is incubator, and second one is uterine cavity. Now, the incubator is open to us, so what we can see about the embryo development. So the next question is, how can we use it to help us and how to use it effectively? The first study is to using time-lapse to evaluate the female underweight on embryo morphokinetics. From this study from London. The woman was grouped according to BNI categories, underweight and normal. They choose the 18.5 as the point. And all ICSI cycles were performed between 2011 and 2012. And totally 336 couples were included, and 34 women were underweight and 224 had a normal BMI. The patient's characteristics were not significantly different between the two groups, except the basic hormone levels are higher in underweight group and FSH dose lower in the underweight group. Now let's look at the time needed to reach the cellular event, the polybody extrusion, pro-nuclear occurrence, and 4-cell, 5-cell, 6-cell, and 8-cell. In underweight group, we can see that a little bit delayed, about 2 hours, they needed to reach each cellular event. And finally, implantation and clinical pregnancy rates were not significantly different between the two groups. So they concluded that almost all cellular events were delayed in underweight women compared to the normal BMI group. And the second study is using the time-lapse imaging to observe the frozen soil blast cyst before transfer. This is a very short period. And this study aimed to assess whether continuous incubation in the embryoscope environment and the time-lapse imaging improve the clinical outcome of blast cyst sowing in transfer compared to standard incubation, only about 2 hours. In this study, 96 vitrified warm day 5 or day 6 blast cyst cycles from 2012 July to October were retrospectively analyzed and divided into two groups. The group A were cultured in the standard incubator, and group B, the 44 cycles in the continuous time-lapse incubator for a similar amount of time, about 2 hours. So let's look at the result. And totally 88.5% of the group A achieved embryo transfer. And out of this, 39% had a positive beta HCG positive. Yeah. And finally, we compare the group A with group B the clinical pregnancy rate per embryo transfer. We can see that in Group B, the clinical pregnancy rate 46.2%, and in the Group A, only 21. So the significance has the statistically significant difference. In Group B, embryos that implanted were found to begin re-expansion before transfer, and before it recovered faster than those that didn't. As usual, protocol dictates that the number of embryos for transfer is a number stored. The Timelapse Imaging played no role in embryo selection for transfer. We're just observing. Now let's look at the expansion time between two groups. In the clinical pregnancy rate, pregnant group and non-pregnant group, the time needed to re-expanding and fully re-expanded are a little bit lower. They expanded faster in pregnant group. So this study demonstrates that the blastocysts incubated in a continuous environment have an improved chance for pregnancy and significantly improved clinical outcome compared to standard incubator. And the associated time-lapse imaging that is used with the embryoscope in fresh cycles to aid selection for transfer is not used before. And of course, it may give more information on extended re-expansion, but we still need more data to prove that and to evaluate that. And another study about using the time-lapse incubator, if it could improve the blastocyst formation. So this study is included the 428 procedures from whom oocytes were collected from August to December 2012. The conventional culture group comprises 1,273 procedures, and from whom oocytes were collected in 2011. So before the 2011, they used the standard incubator, and in 2012, they in some cycles, in some procedures, used the embryoscope culture. So it's a different year. So all the cycles included a clomiphene or letrozole cycle, the microdose stimulation cycles, and for blastocyst culture for up to 7 days. The embryos of the embryoscope culture group were removed from culture chamber twice at day 3 and day 5, just to change the media. And let's see, in the standard incubator group, how many times they will move the chamber out. The morning of day 1 for the confirmation of fertilization, and in the afternoon of day 1 for the confirmation of cleavage is not a routine way, I think, in most centers. And every morning from day 2 to day 4, do you do that? From day 5 to 7 for blaster cryopreservation. So totally 17 times for inspector. The culture condition were as follows. As usual, I think the incubator was performed in embryoscope culture without humidification, and the conventional culture received incubation with humidification. So let's see the good blastocyst formation rate. In this group, in the time-lapse imaging system group, the good blastocyst rate significantly increased, reached to 40%, and in conventional incubator, 3%, and also quite good. And in this pregnancy rate, in the ES group, 48.9%, but in conventional incubator, the more than 50%. No significant difference. So the conclusion is using ESHRE probably will improve the culture environment and then increase the success rate when obtaining more good quality blast cysts. This study from USA and using time-based embryo selection, time-lapse analysis to evaluate dynamic assessment probably will improve the embryo selection. This study using time-lapse imaging to dynamically assess fragmentation and examined the incidence outcome of 4 embryos with early fragmentation in a clinical IVF setting. And this belonged to the morphology assessment. The observation study using the EVA test. EVA test scoring mean early embryo viability assessment has already published in Caihong in the fertility and sterility from Caihong and still in press in this year. The EVA test was developed to automatically measure cell cycle timings and predict blastocyst outcome at the cleavage stage. The EVA is the first automated test validated for utility, safety, and efficacy. So in this study, 95 patients with 850 embryo imagined from June 2011 to October 2012. So this is a retrospective analysis of 137 embryo transferred. Evaluated fermentation and cell division timings, the P2 time from cell 2 and to cell 3, and the P3 time from cell 3 to cell 4 is a period of time. And the implantation were confirmed, actually clinical pregnancy confirmed by ultrasound examination, the 6 weeks gestational age. And they observed that fragmentation occurs in 94% of all embryos observed, and almost from the 2-cell stage. And our results, we divided them with high and low, and correlated with P2 and P3 time. P2 time window and more than 9 hours and less than 11, and P3 time more than 0 and less than 1.73 hours. So in lower EVA score group, the implantation rate is only 6%. That in high score group, 38%. That's significant. So EVA results, how about the EVA results combined with morphology assessment with fragmentation? So in the fragmentation is categorized as negative if the fragmentation less than 10%, and more than 10% defined as a positive. So we combine them. The fragmentation negative is good. Negative and high EVA score, we can see that if we transfer these embryos, the implantation rate reached 46.2%. And the fragmentation positive, but the EVA scores higher. The implantation rate is 27%. If the EVA record score is low, fragmentation positive or negative, even very low implantation rate. So we can, the EVA score high and the fragmentation negative, so we can help us to choose the best blastocyst to transfer. So the study concluded that adding early fragmentation assessment may further improve cell cycle timing-based embryo selection. So this study is using the time-lapse microscopic analysis to exploring the dynamic of embryonic development following blastomere biopsy for PGD. And in the PGD or PGS, we still have many problems and many questions about which day to perform biopsies better, day 3 or day 5, and how about the embryo development after biopsy. So this study is included by static evaluation. Yeah, many studies have evaluated this to try to answer these questions. This study reported that the number of removed cells does have an impact on development. And in mouse blastomere removal resulted in an early compaction. This in another study. This study published in 2009. They found that a trend towards development delay after blastomere biopsy has been observed. So today, we still re-evaluate the morphokinetics because we have a new method, new technology as time-lapse analysis. So up to date, there is only one publication with time-lapse analysis of PGD embryos. So probably this is the second one. So embryos from all PGD treatments were included from September 2012 to March 2013, were cultured in time-lapse incubator until day 4 to day 5. And 47 cycles were included, and including monogenic disorders, chromosomal translocation, sex selection, and 300 embryos underwent biopsy, but 3 cycles discarded, dropped out because no embryo transfer. So totally, 104 embryos were evaluated using morphokinetic parameters, and time points of key embryonic developments before and after embryo biopsy were registered. This outcome is about PGD, and 44 cycles with embryo transfer. The ongoing pregnancy rate is 20%, and the pregnancy rate, a beta HCG positive per embryo transfer is 39%, and implantation rate only 11%. And about the blastomere biopsy was performed most of them performed the 8 cells. So you can see from this, more than 90% of transferred frozen embryos be biopsied more than 7 cells. And how about the development of the blastomere after biopsy? This means addition of cells. This is the first cleavage following biopsy. And 19% of embryo added cells after biopsy. And the time to first cleavage following biopsy, about 8 hours. And how about we perform the 1-cell biopsy or 2-cell biopsy? How about the cleavage time after biopsy? You can see that we only perform 1-cell biopsy, first cleavage time about 80 hours after following ESHRE, and another group is 77 hours. So the only one that needed more time. The compaction following a biopsy, you can see 85 embryos underwent compaction before embryo transfer. And in the following biopsy, the embryo will first cleavage and then undergo compaction, each about 8 hours. And the biopsy of 2 blastomere significantly affects the dynamic of embryo development. So these results may have broader implications in choosing the optimal timing for blastomere biopsy for PGD. So this study is to evaluate the mother's age if they can delay the embryo development, so using the new method, time-lapse imaging system. As we know, maternal age is the most significant factor to affect embryo implantation potential due to the increased incidence of aneuploidy. So aneuploidy embryos have been shown to have delayed embryo morphokinetics. So this study, they're using the new method to evaluate, this is a retrospective study to evaluate the maternal age's effect on the embryo development. The following ESHRE cycles, hours for embryos to reach the 2-cell, 3-cell, or the cellular events were recorded. Embryo morphokinetics parameters were also compared between embryos derived from older and younger. So how to define older? The 13 years old. The patient age did not significantly affect the time for embryos to reach the cleavage stages, and younger patients reached the molar expanded blastocyst, hatched blastocyst stage faster than older patients. That means if the younger and the older mother, the embryo from the different groups mothers, and they can develop the same in the early stage, in the cleavage stage, but in the blast stage, they need more time in the older mother. So probably like with older people or the younger people, we can run the same in the first 10 minutes, 10 meters. So in the longer, probably we were slower than the younger people. So that's the same. And as all expected, the mean FSH dose for older patients is significantly greater than for younger patients. So another question arises. So if the effect caused by the age or by the more FSH used. So this study improving our understanding for how these parameters interact with current establishment predictors of implantation, such as age, and may aid in the formation of models to predict implantation. So such models would have considerable clinical value with the potential to improve IVF success rate. This study to help us, if we can use this method to help us to evaluate the oocyte versus embryo vitrification, the effect after agonist trigger to preventing OHSS. In the women, at high risk of OHSS, we usually use the agonist triggering in antagonist cycles. And also we can choose the freezing all embryos or freezing the oocytes. So mostly I think we should choose freezing all the embryos. But in some countries, the embryo freezing is not allowed. And also we can evaluate if the oocyte be freezing and then you can share the embryo donate oocyte to other couples. So it's also another way. But the question is we should evaluate if the oocyte freezing is good or not. So this study to evaluate 96 patients at high risk for OHSS. And this is a randomized study. In this study, no single case of OHSS was observed. And the cumulative pregnancy rate and miscarriage rate are higher in the embryo freezing group. And implantation rate and ongoing pregnancy rate is also, implantation is also higher, but without significant difference. But you can see that although with the significant difference, but the cumulative pregnancy rate is quite similar between the two groups. And they concluded that oocyte and embryo vitrification after triggering with GnRH agonist are both safe and efficient protocols when OHS risk is suspected. So this protocol resulted in excellent clinical outcome, so they could probably provide us another option. And I do believe that in most centers, we don't have the time-lapse imaging system. So how can we still struggling? And if we can use another biomarkers to predict the outcome of pregnancy in IVF cycles. So in these studies, and to not using time-lapse technology and to evaluate the influence of sequential scoring in determining the best embryo. And as you know, the time-lapse imaging system to provide the early development of embryo. So if we can to check more time to judge the early development and in day 2, and usually we check the development, the cleavage stage development in day 3. So this study plus 1 check in day 2. The cases were randomly selected to be either classified or not on day 2. And the pre-implantation genetic diagnosis, day 2 transfers, oocyte donation, and when all the embryos were vitrified were not included, all the embryo transfer cycles. And a total of 112 IVF cycles were analyzed. The study was conducted from April to December of last year. This study was divided into day 2 plus day 3 scoring and only day 3 scoring. And let's evaluate the clinical pregnancy rate and implantation rates. Sorry. In group 1 had 59 cycles and group 2 53 cycles. The groups were similar among patients' age. And group 1 had 116 embryo transferred, and group 2 had 102 embryo transferred. And the pregnancy rate and implantation rate were similar for group 1, were 22 and 15. But in group 2, the implantation rate is 34% and pregnancy rate, and 24% for implantation rate is higher, but without significant difference. I think probably due to the small samples. And we divided in the pregnancy positive group and the pregnancy negative group. In group 1, day 2 plus day 3 check, the pregnancy rate is 22%, and in group 2, 34%. So they're not significant between two groups. And about implanted or non-implanted, in group 1, the 15%, in group 2, 24%, without a significant difference. So they concluded that there's no significant difference between group 1 and the 2. That's useless to press the day 2 check. And also we try to find the biomarkers in the blood or the serum or in the follicular fluid, and to find out the biomarkers to predict the outcome of our pregnancy rate of IVF cycles. So this study, and also using the gene polymorphism of vascular endothelial growth factor, and to predict pregnancy outcome after IVF cycles. And this study is a prospective cohort study, was conducted from February 2011 to June 2012 in 102 infertile women was subjected to IVF ESHRE protocols. And the patients were evaluated for the presence of different VEGF gene, 1154AA, GA, and GG. The individuals were genotypes using real RT-PCR for the VEGF gene test. And among the gene type, the age, M2, oocyte, and embryo transfer and implantation rate, there's no significant difference. And in the ongoing pregnancy rate, you can see that in group A, AA gene type, they reached 50% pregnancy rate, but in group B and group C, only 20%. So the reported that probably the gene expression, the different gene type, predicting pregnancy outcome during IVF treatment based on these markers. And also we can check the cytokines and other biomarkers such as DHEA to predict the oocyte fertilization potential and pregnancy outcome. And we usually use the DHEA, have already used, and to improve the ovarian resume and improve the outcome of older women. So of course, this study is not performed in non-PCOS women. So this study is a prospective cohort study of 249 conventional downregulation stimulation protocol in non-PCOS. The ESHRE cycles were excluded. And we check the follicular fluid DHEA levels. The fluid is pulled from follicles, from all follicles, not single follicles, and retrieved. And fertilization failure cycles were excluded when comparing pregnancy rate. So we can see that fertilization failure cycle demonstrates significantly lower levels of follicular fluid DHEA levels. And in the pregnant group or non-pregnant group, the follicular DHEA levels is different. The difference is with the statistic significant. In pregnant group, the follicular fluid DHEA levels is higher. And also E2 level was higher. And the fertilization is also higher in pregnant group. And we divided two groups according to the follicular fluid DHEA levels, the high and low. And we can see that the follicular E2 level fertilization rate, clinical pregnancy rate, live birth rate, and fertilization failure cycles, all the differences with significant, statistically significant. So the higher is better. So this is the comparison of parameters between the pregnant and non-pregnant groups. And this is another groups, high and low follicular fluid DHEA follicle. So follicular DHEA probably is a possible biomarker of oocyte fertilization potential and an effective indicator, probably. And actually, in our own experience studies, we can see that actually it's difficult to check the biomarkers in the follicular fluid because it's difficult to retrieve and collect the clear fluid and for the single follicles. So, and also there are numerous biomarkers and numerous molecules in the follicular fluid in our serum in our body. So I think, I don't know what's your opinion. It's very difficult to find out one or two to predict so difficult and complex the procedure of pregnancy. So also we come back we usually to believe what we saw and but also usually what we saw probably will cheat us. But time-lapse imaging is still the good method to help us to predicting. So next I should introduce this is a randomized pilot study if it can help us to predict the high potential embryo and to perform the single embryo transfer. And this study was conducted to determine whether or not there are advantages or disadvantages of time-lapse imaging system. And the total included 64 patients and randomized to two groups, the time-lapse incubator group and a conventional incubation group. And for patients in the TL group, a single blast cyst was selected according to the morphology and other criteria, T5, S2, and CC2. So what's the meaning of CC2? According to the cell 2 and cell 3 and cell 4 and cell 5, the period of time, and also the period, the cleavage between the 1 cell and 2 cell to 3 cell and another. So this interim analysis showed that the positive effect for CI at day 3 and day 5 rates very similar between the good quality and the top quality. The pregnancy rate and miscarriage rate are not significantly different, so there's no apparent advantage to time-lapse imaging system. So this interim analysis performed revealed no statistical difference between the both groups for blastocyst development, so a little bit disappointed. And also, how can we use it to help us to evaluate another method, such as oocyte activation inference? So this study aims to evaluate if artificial oocyte activation using calcium ionophore has an impact on embryo development, and we just use time-lapse imaging to help us to evaluate. So this is a retrospect study. This study included ESHRE cycles, or 92 cycles, 78 standard, and 14 oocyte activated. The fertilization rate was higher in the standard ESHRE group compared with the oocyte activation group. And however, many morphokinetic parameters were similar between two groups. And pregnancy rates were higher in the standard ESHRE group. So probably the activation may have the bad or the worst effect on the embryo development. So embryo results from artificial oocyte activation behave like standard ESHRE embryos. The commonly assessed time points of embryo development are not significantly different between the two groups. So thank you very much.
Thank you very much, Professor Ma, for a very excellent presentation regarding the update of embryo technology. So we almost can say that to date, the update and the progress of embryo technology almost equal to time-lapse microscope, right? So a lot of effort try to extend the application for the time-lapse to on the assessment of embryo. So I wonder, is there any question or comment from the floor regarding the assessment of embryo for new technology? Is there any country and region have experience for time-lapse microscope?
So still need to evaluate if this method is promising or not, right? So, and how and what this method can help us and how. So we should evaluate critically, I think. Actually, we have already ordered this system, but it's not available in our center. So how about your appearance? If it's
yes, please introduce yourself. And
yeah, we don't have the time-lapse imaging apparatus. According to you, all your review of the abstract in this year, what is your opinion about time-lapse imaging? It will be beneficial, will be helpful for us for the embryo or oocyte evaluation?
Yes, I think the benefit of this system only to check to let me know how about the embryo development in the early stage, because in the day 2 and we don't know what's the development, and during the cleavage, the day 2 to cell 2 to cell 3 to cell 4, how about the time they need for each embryo? So this system provides this data for us. So probably I don't know if the embryo developed not quickly, just step by step, very good. So probably this is a prediction to help us to judge this embryo is good. But it's not correct, I think. Probably as human being, in the childhood, I develop not good and not quite slow. But in the youth, the period, I develop and my study on my development is about more body or about brain develop very good. So you not can judge a person by this time only by the time. So I think the combination with the fragmentation, the morphology, the routine way as we use it today, the morphology assessment and the fragmentation percent, and combined with the time will be better. And also can be only used in some selected group of the patients. Perhaps, for example, in the recurrent implantation failure group, or very difficult the patients, I think we can try that. And not suggest to use the routinely in all the cycles, all the embryos, because we even don't know. Probably it has a bad effect, the worst effect on the embryo development.
Thank you, Kola.
You had made one presentation in which, from Istanbul, I think it is a randomized trial, that is actually not in favor of this, am I right?
Sorry?
You made one presentation from, I think it was from Istanbul, in which they've done a randomized trial looking at time-lapse monitoring. That isn't actually in favor of it.
Yeah, don't favor it.
So
yeah.
I think that's one of the very few randomized trials which have
Yes.
actually been shown, and all the other trials are really not randomized.
Yes. We still need more data, more studies, and to multiple center study to confirm that, the effect, and also the bad effect.
Any further comments? Yes, please.
All right. I'm Dr. Caihong from Taiwan. So I'm interested in one of your slides. You mentioned that the follicular fluid, DHEA, is probably an indicator for a better pregnancy outcome. So do you suggest, or in your setting, do you suggest that the DHEA supplement is probably a way for us to improve the pregnancy outcome? Do you think that's an idea?
Oh, very interesting question, a very good question. And also, as we know, the DHEA, and many studies have demonstrated that a supplement of DHEA probably will help to improve the oocyte reserve in the older woman, because in the older woman or in the lower ovarian reserve women probably will have the good outcome of the pregnancy, but the benefit or the effect is quite low, I think. So, and also this is another choice for us to check, to evaluate if the DHEA exists, the exact effect in the woman, in the non-PCOS women. And so we try to check the DHEA levels in the follicular fluid. So if they can, to confirm our experience in the use of drugs to help the low ovarian reserve the women. So according to this study, the higher level of DHEA was better for the oocyte fertilization rate. So this is probably a promising result for us. So we could include expanded that study or supplement for the DHEA and to the older women and all in the selected women probably will higher benefit. Okay.
I totally agree with that because it's very difficult that we interpret the result from the paracrine level, for example, follicular fluid, to interpret the endocrine level, supplement by anything, probably try to improve the outcome. Yeah.
I have one.
Yes.
I have a comment to make. When a few years back, a cell spindle has come into place, where in a spindle view, if somebody did not have that equipment, they said you're lagging behind. And at the end of a decade, you see, for all practical purposes, except in research setting, it has disappeared. Similarly, when you look at cell spindling, poloscope, a parameter has come in the evaluation of zona, where it was proved beyond doubt that inner zona has a role. But one thing when it comes into the real life scenario is, can we use it on an everyday, day-to-day based tool? That was one other thing. The third thing is, when you look at time lapse or the morphometric analysis, one thing is, it has a role when you're reducing the number of embryos. Second thing is, it has a role when you have many embryologists and try to titrate who is better in that, or have a better communication of the feedback from the embryologist. And it's a learning tool for the embryologists to improve their scores over a period of time. That's what I see about this time-lapse imaging in the next 3-4 years.
Thank you very much. Thanks for excellent comment for that. Okay. So we thanks again for Professor Ma for her efforts.